Hello, I'm Hyun from the Veterans Health Service Medical Center in Seoul, Korea. Today, I'll briefly summarize our multicenter study. Does protocol heterogeneity in active surveillance influence clinical outcomes? Active surveillance (AS) is now a standard management approach for men with low-risk prostate cancer. The goal is straightforward: reduce overtreatment while maintaining oncologic safety. But in real-world practice, AS is not delivered the same way everywhere. Institutions differ in eligibility criteria, whether they do a confirmatory biopsy, and how intensive the monitoring schedule is. So the practical question is, do these protocol differences change what happens to patients, how long they stay on surveillance, when they switch to treatment, and what we find if they undergo surgery? We retrospectively reviewed 232 men who initiated AS between 2014 and 2016 across 3 hospitals, each using a distinct protocol. Here's the key difference. Hospital A included glycine grade group 1 and 2, PSA under 15, and did confirmatory biopsy only if clinically indicated, for example, PSA or MRI change or patient anxiety. Hospital B included grade group 1 or selected grade group 2 within core limits, PSA under 20, and mandated biennial biopsies. Hospital C was the strictest on eligibility, mainly grade group 1 within core limits, and recommended one confirmatory biopsy within 1 to 2 years, then biopsy only if clinically indicated. So, in simple terms, Hospital A was less biopsy intense, Hospital B was scheduled biopsy intense, and Hospital C was strict on entry plus only confirmatory biopsy. Across the full cohort, the median AS duration was about 38 months. When we compared AS continuation, 5-year retention differed significantly. 53% in Hospital A, 79% in Hospital B, and 59% in Hospital C. So, Hospital B, where biennial scheduled biopsies were used, had the highest long-term retention on surveillance. Next, treatment transition occurred in 23% of patients in Hospital A, 18% in Hospital B, and 44% in Hospital C. Hospital C had the highest conversion rate, and transitions were predominantly to radical prostatectomy. Meanwhile, in multivariable analysis, Hospital B had the lowest hazard of transition, about half the risk compared to Hospital A, whereas Hospital C showed a higher hazard of prostatectomy versus Hospital A. Now, the most clinically important question: did these different strategies translate into differences in surgical pathology among men who ultimately underwent radical prostatectomy? In our data set, final grade group and pathologic stage did not differ among prostatectomy specimens across institutions. Our interpretation is that protocol differences mainly affected the clinical pathway, how long men stayed on AS and when they moved to treatment. However, despite different pathways, surgical pathology was similar among institutions. At the same time, we should be cautious. Baseline characteristics differed across hospitals, and the number of prostatectomy cases was limited. So, the absence of difference in pathology should not be overinterpreted. To conclude, institutional heterogeneity in AS protocols significantly influenced surveillance duration and treatment timing, but not adverse pathology at surgery. This suggests that flexibility in protocol design may be acceptable as long as it's anchored by safeguards, particularly confirmatory biopsy and risk-adapted monitoring. And ultimately, our findings support the need for evidence-based standardization so patients can receive consistent, safe, and practical AS care across institutions. Thank you for watching.